So I will talk today about the KDIGO-Bundles and a multidisciplinary rapid response team for AKI. Here are my disclosures. Nowadays, we use the KDIGO criteria to diagnose and stage AKI based on changes of the serum creatinine and or urine output. However, we have to keep in mind that these functional markers have certain limitations. So the serum creatinine levels have a low sensitivity because the serum creatinine levels only increase if more than 50% of the GFR is lost, and you also know that the urine output has a low specificity because it can be influenced by several factors, for example, the use of diuretics or hypovolemia. Eric Horst and colleagues demonstrated that acute kidney injury is a common complication in critically ill patients. This is a large observational study in 97 ICUs, and they included more than 1,800 patients, and they demonstrated that more than 50% of all ICU patients developed an acute kidney injury, and they also demonstrated that the development of an acute kidney injury is associated with an increased mortality. So patients who developed a severe AKI had a mortality up to 65%. Acute kidney injury is a continuum that starts with an increased susceptibility and ends with an organ failure. An increased risk based on different comorbidities and a certain clinical condition, for example, sepsis or major surgery and a kidney damage, are clinically silent. We cannot use the serum creatinine and or urine output to diagnose this. If we have a disease progression, the GFR goes down, and at the end, we have an organ failure. In order to identify the golden hour of acute kidney injury, we need biomarkers, and this is highlighted in this study by Michael Haas and colleagues. Here, they recruited more than 2,000 patients and divided the patient into 4 groups based on the serum creatinine levels and biomarker level, and in this case, they used NGAL as a biomarker. First of all, they divided the patient based on the serum creatinine levels. In patient with an elevated serum creatinine level, the 2 groups on the right side, and patient with a normal serum creatinine level. And in the next step, they divided them based on the biomarker and biomarker negative and biomarker positive patients. So patients with a normal serum creatinine and a normal biomarker level had a low dialysis and mortality rate, as you can see here on the left side. However, patients with a normal serum creatinine level and an increased biomarker level reflecting a kidney damage without a loss of function had a significantly higher dialysis and mortality rate, suggesting that a kidney damage without a loss of function impacts patients' outcome. Based on this study, a new term was introduced, and this is the subclinical AKI. And here on this slide, you can see the relationship between kidney damage and kidney function. On the x-axis, you see the kidney damage. On the y-axis, you see the kidney function. So normally, we are hopefully all in the upper left panel. If there is a damage, we move to the upper right panel. So there is a damage without a loss of function. That's subclinical AKI, and if we have a disease progression, we move to the lower right panel, so there is a damage with loss of function, and this is intrinsic AKI. The good news is so that we can also move the other way, in the context of renal recovery. Based on these data, some experts in the field ask for incorporating these damage biomarker in the definition of AKI, and here on the left side you see the functional criteria, so serum creatinine and or urine output, and on the right side you see the damage markers. Nowadays we know a lot of biomarkers, and the best evaluated biomarker is probably still NGAL. It has a high sensitivity and high specificity. However, recent trials demonstrated that NGAL levels can be influenced by certain comorbidities, for example, chronic kidney disease. IL-8 is another biomarker which has been investigated mainly in patients undergoing cardiac surgery, and here the biomarker has a good performance. However, we can only measure 3 biomarkers at the bedside, and this is NGAL, TIM2, and IGF-BP7. And here we can measure the biomarkers by using a point-of-care device. We only need a small blood sample or urine sample, and then we can measure the biomarkers within 20 minutes. And based on the biomarker, we can either implement a therapy or change our therapy. But in the next couple of minutes, I will focus on TIM2 and IGF-BP7. So these 2 molecules are involved in the cell cycle arrest. What is a cell cycle arrest? Normally the cells, also tubular epithelial cells, are in the cell cycle, and once they get damaged, they can leave the cell cycle and go into the cell cycle arrest. And here they are protected from further damage, and they have enough time to recover from the damage. And once they have recovered, they can enter the cell cycle again. In the SAPPHIRE trial, which was published back in 2013, the authors identified TIM2 and IGF-BP7 as AKI biomarkers, and in a large observational trial, they looked whether the biomarkers can predict a moderate and severe AKI after ICU admission. And here you see that the performance of TIM2 and IGF-BP7 was significantly better compared to other known biomarkers, for example, cystatin C, KIM1, NGAL, and so on. And we use the biomarkers in order to look whether they can predict an acute kidney injury after cardiac surgery in high-risk patients. And we identified these high-risk patients by using the Cleveland Clinical Foundation scores. So this score consists of different risk factors, and for each risk factor you get a certain amount of points, and the number of points you get correlates with a dialysis-dependent acute kidney injury. So we measured TIM2 and IGF-BP7 at different time points before surgery as a baseline, 4, 8, 12, and 24 hours after cardiac surgery. And we first of all looked for the performance, for the composite value. So here we took the highest TIM2 and IGF-BP7 value within the first 24 hours. And here you see the area under the curve. This is 0.896. This is quite good. 1 would mean you have a perfect biomarker. This biomarker doesn't exist. And 0.5 means you can flip a coin. However, if you only want to measure the biomarker once, you should measure it 4 hours after cardiac surgery. Here, the area under the curve is still quite good. It's 0.805, and this was significantly better compared to the area under the curve of NGAL. This was only 0.679. So biomarkers can predict the development of acute kidney injury, but we shouldn't measure biomarkers in all our patients because then the specificity goes down. That means if you, for example, measure troponin I in all your ICU patients, you will find patients with an elevated troponin I also they haven't suffered from myocardial ischemia. Unfortunately, acute kidney injury is not painful, and we often don't know when the injury occurred. And back in 2010, Stuart Goldstein and Ming Shala came up with the renal angina concept. And this concept says that we should only measure biomarkers in patients with a certain risk profile, consisting of different risk factors, as you can see here on the left side, for example, chronic kidney disease, chronic heart failure, and so on, and a certain clinical condition, for example, patients with sepsis or after a major surgery. And if the biomarkers are elevated in these high-risk patients, we can start a therapy based on the elevated biomarkers, for example, start renal replacement therapy. So in the last couple of years, several trials have been performed investigating different measures to prevent or to treat acute kidney injury, however, without any success. So there is currently no specific therapy available. So in the next couple of minutes, I will talk about the KDIGO-Bundle, and in the last part, I will talk about the multidisciplinary rapid response team. In 2012, the KDIGO guidelines were published, and the guidelines recommend to implement a bundle of different measures in high-risk patients. And this is different from the sepsis guidelines, because the sepsis guidelines recommend to implement the sepsis bundle in patients with an already established sepsis. And here we should apply this bundle to high-risk patients. And this bundle consists of discontinue all nephrotoxic agents when possible, ensure volume status and perfusion pressure, consider functional hemodynamic monitoring, monitor serum creatinine and urine output, avoid hyperglycemia, and consider alternatives to radio contrast procedures. So these measures are really easy to implement, and we should implement them in high-risk patients, and we can, of course, use biomarkers to identify high-risk patients. And we wanted to know whether the implementation of the KDIGO bundles can reduce the occurrence of acute kidney injury in patients undergoing cardiac surgery. This was a single-center trial which we performed in Münster. And here you see the study flow. So we measured TIM2 and IGF-BP7 in all patients undergoing cardiac surgery, and we defined high-risk patient as patient with an elevated TIM2 and IGF-BP7 level equal to or higher than 0.3. And these patients were randomized into a control group. Here, the patient received the standard of care therapy. We only kept the mean arterial pressure above 65 and the central venous pressure between 8 and 10 millimeter of mercury. And in the intervention group, we applied the KDIGO bundle. So we discontinued all nephrotoxic agents when possible. We also discontinued ACE inhibitors and ARBs because it is known that these drugs can cause hypotension in the perioperative period, and this is associated with AKI. We optimized the hemodynamic situation, and we used a really easy algorithm. I will show you the algorithm on the next slide. Monitor serum creatinine and urine output, avoid hyperglycemia, and consider alternatives to radio contrast procedures. And here you see the hemodynamic algorithm we used. First of all, we looked for the volume status by using the stroke volume variation. If this was too high, we gave volume. In the next step, we looked for the cardiac output. If this was too low, we gave positive inotropes. And in the last step, we looked for the mean arterial pressure. If this was too low, we gave vasopressors. If we achieved the goal, we checked the algorithm every 3 hours up to 12 hours. If not, we started from scratch. First of all, we looked for the performance of the biomarkers. And we saw that 72% of the patients with an elevated biomarker, that means a TIM2 and IGF-BP7 value equal to or higher than 0.3, developed an acute kidney injury, in contrast to 21% of the patient with a low biomarker. We also calculated the negative predictive value and the positive predictive value. The negative predictive value was 79% and the positive predictive value was 72%, so quite good. And here you see the measures during the intervention period. More patients in the intervention group received positive inotropes. In this case, dobutamine, so 30% of the patients in the intervention group received dobutamine and only 9% in the control group. The incidence of hyperglycemia was significantly reduced in the intervention group compared to the control group, and less patients in the intervention group received ACE inhibitors and ARBs. The implementation of the KDIGO bundles in high-risk patients identified by using biomarkers significantly reduced the occurrence of acute kidney injury after cardiac surgery. So here, if you look at all AKI, this was significantly reduced from 72% to 55%. And if you only look at moderate and severe AKI, this was also significantly reduced from 45% to 30%. Based on this study, John Kellum wrote a nice article, and he wrote, AKI, the myth of inevitability is finally shattered. And he also wrote, now that evidence demonstrates that AKI can be prevented, it is our duty to find more ways to do it. Of course, our study was not without any limitation. It was a single-center trial, and we focused on a specific patient population. Fortunately, 3 months after our study was published, another study was published, and the authors used exactly the same approach. So they identified patients at high risk by using biomarkers, but they focused on another patient population, so they investigated patients after major surgery. So they randomized 121 patients, and here you can see they also used TIM2 and IGFBP7, and the high-risk patients were randomized into a control group. These patients received the standard of care therapy, and in the intervention group, the patient received more fluid, and a nephrologist was consulted, and he was supposed to maintain a perfusion pressure and discontinue all nephrotoxic drugs. The primary outcome was AKI within the first 7 days, and by implementing this approach, the authors demonstrated that the incidence of AKI could be reduced here on the left side, and if you only look at moderate and severe AKI, this was also significantly reduced, and this was associated with a shorter length of ICU and hospital stay. However, the problem with guidelines and bundles is the adherence to the bundles, and this is shown in this study. And if you look at this box, the sepsis bundles, the author here demonstrate that only 34% of the patients, of the septic patients, are treated according to the sepsis bundles. And this is also true for other bundles and guidelines. However, Professor Ronco and his team here in Vicenza implemented a program in their daily practice to prevent and treat acute kidney injury. And this is a multidisciplinary rapid response team. And this is a team of physicians who are on call 24/7, and they get informed once a patient is at high risk or has an acute kidney injury. And they use the F4 model for risk assessment, so that means clinical scenario, past history, physical examination, and lab results, including biomarkers. And they work off a checklist, and then they score the patient for the risk, and there is a low risk, moderate, and high risk group, and they add biomarkers, or they measure biomarkers in patients with a moderate and high risk, and once a biomarker is elevated, the multidisciplinary rapid response team is informed. And this team is supposed to stratify AKI stage, avoid AKI evolution, find the cause, and follow up at hospital discharge. And they generated an app, and the physician gets the information on the app, and this app says, okay, here there is a patient who is at high risk. And then the physician goes to the patient, they work off a checklist, and then they apply a bundle. And by using this approach, they were able to reduce the incidence of AKI, as you can see here, and they also reduced the need for renal replacement therapy by 20%. So in conclusion, we can say subclinical AKI worsens outcome. Biomarkers can identify patients at high risk for AKI and kidney damage, but we shouldn't measure biomarkers in all our patients because then the specificity goes down. We should only measure biomarkers in high-risk patients. We should start the treatment early. We shouldn't wait until the kidney function declines. We should start earlier when there is a kidney damage, and recently published data suggests that biomarker-guided implementation of supportive measures reduces the occurrence of AKI. Thank you very much for your attention.